Hello and welcome to the COVID-19 Fatigue webinar. My name is Hugh Cook and I'm a member of the communications team at Public Health Wales. I also am one of the leaders of Work Package 2, Communications Dissemination Work Package of the SHARP Joint Action. Today is an opportunity to share best practice and talk through some of the lived experiences of delivering work that reflects just some of the core strategies and principles set out in the COVID-19 Fatigue framework. And this, as I've mentioned, this event is brought to you by the SHARP Joint Action. For those of you who may be new to SHARP, we're a 3-year joint action co-funded by the Health Programme of the European Union. Our aim is to strengthen preparedness in the EU against serious cross-border threats to health and support the implementation of international health regulations. We launched in 2019 and little did we realise at the time just the type of journey that we would be going on. And in many ways we've been able to adapt to the situation and really take on board the learnings from the COVID-19 pandemic. SHARP as a collaborative is proud to have contributed to the pan-European response, and indeed most, if not all, of our SHARP partners have been leading forces in their own national responses. And today is very much a response to some of that learning. Risk communication has been identified as one IHR core capacity that needed the most strengthening. And that isn't surprising if we consider that this pandemic is the first global emergency of the digital age. If we think back to the 2019 influenza pandemic, for example, Facebook and Twitter are still very much in their infancy. And now, all of these years later, we're seeing so many more platforms, and on all of these platforms, we're seeing so many more thousands of sources of information. And we're really trying to combat some of these sources of information when it comes to misinformation or disinformation. So this is where the COVID-19 framework particularly has a really important role. But rather than introducing that myself, I'm very honoured to welcome one of the co-leads that wrote the COVID-19 framework. So I'm very proud to welcome Katrine. Katrine, over to you.
Hello, and thank you very much. I'm just going to share my presentation and introduce myself. So I'm Katrine Bach-Habersot, and I am acting team lead and regional advisor for behavioral and cultural insights at the WHO Regional Office for Europe. And as Hugh was saying, I developed the fatigue framework that we're going to talk about today, together with my colleague, Andrea. She's the beautiful young woman that you see here on the screen at the bottom. And we developed it together, obviously, with the input of a range of very many other people who provided input, including through reviewing it. And I even saw some names here of you, some of you here today have reviewed the framework in the early phases. So thank you for that. And I do feel quite humble and grateful that this whole meeting is to discuss the framework. Obviously, it's always very, very gratifying when something that you've worked on is found to be useful by someone else. So thank you for that at the very beginning. But I was asked to talk a little bit about why we developed the framework and how. And so I'll just take you back to last year in September when we developed the framework. And this was the situation we saw in many countries. This is from one country. We saw that the number of people who were keeping themselves informed regularly about the pandemic was decreasing. People who were keeping up protective behaviors, the same. People who had high risk perceptions. We saw in many places the same, the percentage was decreasing. And countries at that stage, we really felt the pandemic had been going on for so long, and it's already a long time ago. But countries were reaching out to WHO and saying, what can we do? What can we do to address this fatigue or this frustration, this situation that we're seeing in our countries? And it wasn't a particularly easy question to answer, I'd have to say, because as we all know, this was a situation that we hadn't been in for 100 years. So there was no straightforward answer. So we reviewed relevant evidence in a number of areas. We looked at the behavioral insights data that we had access to. I showed you the example from one country before. We have worked together with a long range of countries in our region and supported them in collecting behavioral insights data throughout the pandemic to understand population behaviors and perceptions and well-being during the pandemic. And we looked at that data as well. And together we used that to develop this framework on reinvigorating the public to fight the pandemic or to prevent COVID-19. And in this framework, we decided to define pandemic fatigue as a completely natural reaction to what people were going through for a long time, and saying it expresses itself as distress, emergent demotivation to keep up protective behaviors and keeping yourself informed, and also perhaps feelings such as complacency, alienation, hopelessness. And we said it's something that evolves gradually over time, and is affected not just by individual emotions or experiences and perceptions, but also very much by external factors, environmental factors like the cultural, social, structural, and legislative environment. So that's what we decided. I think very fairly enough, we introduced this concept building or rooted in evidence as we could, but also very much in the situation as we experienced it at the time. And there were some scholars who questioned a little bit that notion of pandemic fatigue and saying, is this really the name? Is it fatigue? Is it something else? And is there strong evidence that this fatigue or this feeling of distress in itself leads to demotivation, and in itself leads to a lower uptake of protective behaviors? And fairly enough, we did see at that time, and we still see, that while people are fed up with this pandemic, the vast majority actually continue to adhere to regulations and recommendations, which is quite impressive. So that's a really interesting discussion, but perhaps a more academic one. And it's important to say that we did talk to these researchers who were from the London University College. And one thing they emphasized is that they found that the strategies that we proposed were very, very appropriate. So that's where we definitely agreed. And I think to explore this issue of whether pandemic fatigue really is a thing, and it exists, a group of researchers from Denmark and Germany then went along and looked at data that they'd collected weekly in the two countries throughout the pandemic to try and explore whether something that we might call fatigue really does exist. And they found that that there are actually two kinds of fatigue. One is information fatigue, so you're really fed up with hearing about COVID-19, and then there's the behavioral fatigue where you feel demotivated to fight COVID-19. And then interestingly enough, or importantly, they saw that these types of fatigue actually do drive non-adherence to the recommended practices. So already now we know more about pandemic fatigue than we did before, and I'm sure it's kind of one of those things that we will continue to explore also beyond the pandemic, and something that is quite interesting and may spill over even beyond crisis or pandemic situations. Anyway, that was a bit about the background. The framework itself includes 4 key strategies and 5 cross-cutting principles and 10 proposed actions, and that's actually what we're going through today. So I'm just going to flip through quite quickly the 4 strategies. The first one is about understanding people. So through these behavioral insight surveys, through focus groups or interviews or social media monitoring, whichever way we can try and understand better the barriers that people are facing, but also what motivates them, what drives them, and most importantly, using that insight to inform action, to translate the findings into policies. The second strategy is about engagement. I think we humans have a very essential fundamental need to feel in control of our own lives, and when that autonomy is threatened, demotivation is very often the result. And so any strategy to reinvigorate the public needs to involve engagement one way or the other. And there are many, many ways to engage, particularly at very low local levels. And I'm always using the example of my own 2 children, which I think they're 13 and 16. I think they're very responsible, but at no point during the last 14 months at their schools, when they have been back to school, have they been engaged in a discussion about how in our classroom or in our school would we like to protect each other? How would we like to keep our schools safe. And I think the kids could have come up with some really good suggestions, but it doesn't seem to be the norm. And I think that's just a micro example of something that potentially happens at all levels of our society, that we potentially haven't been good enough at asking people, what do you think and how would you like to adhere to recommended practices? Second strategy, it's built on the notion that the human mind is interesting, that if you ask somebody to do something they think is feasible and realistic, we're likely to do it. If we're asked to do something that we think is unrealistic, we're likely to not even try. So this draws on more of a harm reduction thinking, where if you have groups in your society where it's either unrealistic or maybe for other reasons undesirable, that they stay completely away from each other. And we have seen, particularly with young people, but also other population groups, that it may not be the best approach to just say, well, you can't do. Then there might be other ways of, maybe through engagement, but providing guidance and allowing people to somehow do what is important to them, live their lives, but guide them in doing so safely, and finding that balance, which of course is incredibly difficult, and sometimes the epidemiological situation prevents that. But it's one of the principles that you might consider. And then obviously we've all lost something in the past 14 months. Rituals like weddings or funerals, or birthdays that we couldn't attend. People have been sick. Some people have lost dear ones. Some people have lost their income. And regardless of what that hardship is, it is something that we know that struggle is a driver for demotivation. So it is something that we need to acknowledge and, if at all possible, address. Even though it's difficult, and it also depends on what the options are in the different countries. I hear someone speaking in my, sorry about that. Anyway, the last slide is here. It's, I'm hearing someone
please speaking. Could you mute yourselves if you're not speaking? Sorry.
Sorry, yes, you're right.
Don't worry about it, not a problem at all. No, the last slide is actually just about the 5 cross-cutting principles, about implementing all of the 4 strategies I've just mentioned in a spirit of transparency and predictability and fairness and consistency and coordination. Obviously not easy during a time of completely changing circumstances and very emotional reactions from everyone, and engagement of so many stakeholders. But the reason why we're emphasizing these 5 principles is that we know that these are the 5 drivers of trust. And obviously we can also see in our data that trust is just a critical factor for everything, for well-being, for uptake of protective behaviors, for everything that we want to achieve with this. So the five principles are really difficult, but they're also really, really important. That's it. Thank you.
Thank you so much, Katrina. It's really interesting to hear kind of, where this has come from, and kind of some of the drivers behind that, and especially kind of, around the information fatigue and the behaviour fatigue as the 2 driving elements behind that as well. And before we move on to our next speaker, were there any questions that people had for Katrina? No, there will be opportunities later on as well if you would like to ask questions again. So yes, on to our next speaker. So I'm really happy to introduce the wonderful Leah Morantz, who will be presenting on the 5 cross-cutting principles that have just been mentioned there as well. So welcome, Leah.
Thanks, you just called me wonderful, so I feel like I have a lot of pressure now, and I have a big role to step into. So Katrina, thank you so much for setting the scene really for what I'm going to talk about next, and I'm hoping that the work that we've been doing at Public Health Wales just gives some examples of how we've tried to apply some of the thinking that you've just talked about. So before I move forward, can I just check, Hugh, can you see my screen now? Can everyone see my presentation? Okay.
Yeah, I can see it.
The only problem with this now actually is that I can't see my notes, so we'll just have to see how we get on.
Did you share your screen as share screen or share presentation? If you share presentation, it should come up with your notes as well.
Shall I go into, sorry everybody, and thank you. So do I go into slideshow or?
No, so if you unshare your screen.
Sorry, I go back to, yes, okay. Everyone's very patient and I'm very grateful. So I go share content.
So share content, and then it should give you the option to share the presentation, which should hopefully.
Okay, so do I click on the PowerPoint section on the side then?
Yeah.
Yeah, okay, no problem. Thank you everybody, and I'm sorry for delaying proceedings here. So hopefully this will work. We did rehearse, believe it or not. So we'll just give that a second to hopefully load up. And how's that looking for everybody? Can you see that now?
Brilliant.
Okay, thank you so much. Okay, wonderful. Well, I think I'll pick up really with the 5 cross-cutting and just let's see if I can actually get my notes to see to view here. Sorry, Hugh, do you know how I can get my notes to show on my screen? I might just have to do this sans notes. Okay, right, we're gonna wing it. Okay, so transparency, fairness, consistency, coordination, and predictability. So I guess what I really wanted to sort of touch on today is obviously, communications is, as Hugh said at the very beginning, risk communications in particular is a core aspect of managing international health regulations and risk in the context of public health emergencies. And of course, it's not the only intervention that is used, and we obviously know that. And I think before kind of going on into the communications aspects that I want to share today, I wanted to just sort of touch that these cross-cutting principles obviously apply to those other interventions and not just to communications, but I'm going to focus on communications and stakeholder engagement today. So hang on, are you changing things around for me? Someone's taking control and we're back. Okay. Hugh, are you presenting on your end for me now?
Yeah, I'll present your end, so you've got your notes as well then.
Oh, you're super kind. Thank you so much. Okay, thank you. So these 5 principles apply to all aspects of managing a public health crisis, as you know, and I said I'm going to focus on communications and stakeholder engagement. And as Katrine said, stakeholder acceptance to any intervention or buy-in to what you're asking people to do just won't happen if you don't apply the principles. We know that communication is not a single step or a component of crisis. It must be fully integrated with the crisis response. And that's something that we talk about when we did the risk communications training seminars as part of the Sharp Joint Action for Health work back in July of 2019 when we met in Vilnius to talk through some of the core components of the project. Effective communication should not be done to a target audience in the same way that public health interventions cannot be done to a target audience. There needs to be that two-way partnership and that understanding that we need to work together and create a shared understanding of the outcomes that we want to drive. And I think it's important as well to say that, the vision is going to trump the information, and that's where the emotional aspect comes in. And Katrine touched on that when she talked about the 4 strategies. So understanding people's motivations and the barriers for them in terms of following the regulations, helping people to feel that they're in control and engaged, and helping them to live their lives but reduce risk, and acknowledging the hardship that people are going through. So if I move on to the next slide, what I'll cover today very briefly is a brief overview of how we've carried those principles throughout all of our response work. And I'll also hopefully demonstrate the interconnectedness and value of these principles, not just in combating fatigue, but also in all approaches to communication. So moving on again, what did we do from the outset of the pandemic? Well, exactly what you would expect the communications team of a public health agency to do. Internal communications, external communications, working with media partners and political stakeholders as well. Proactive campaigns to really work to get those messages out there. We worked very closely with the media from the very beginning, stakeholders and partnerships, and working with social media as you would expect. And the big question I suppose that many people have asked me is, how was it different for you, Leah, running a team and running the communications for a public health agency through the pandemic that we've been living? And for me, my answer to that is that it's just been more volatile, more uncertain, more complex. and more ambiguous than anything that I've experienced in my career, and probably more so than what many of my team have experienced, certainly in their careers as well. So if I move on again and just focus a little bit more on what we did during the first kind of part of the pandemic, and what we've done in this presentation is we've just kind of put the key at the top to show which aspects of the cross-cutting principles we applied to this, bearing in mind what I'm showing you now is the examples of the work that we did in the first half of 2020, and I'll move on to what we're doing now. So it's kind of a retrospective review of the work that Katrine talked about. And when we looked at how we applied our campaigns, we did find that predictability and consistency were two key elements. So in the first 4 months of the pandemic, we applied ourselves really hard to consider how we were going to get the messages to people. And we focused on 3 campaigns in the first few months. The first one was a thank you campaign. The second was around public health protection and sharing specific messages so people could understand what we were asking them to do. And the third was a specific campaign around mental, social, and physical well-being. So that first one, if I move on to slide 6, you can see some famous faces. They're probably famous for people who live in Wales or the United Kingdom. But this is one of the things we did was work with people who are very well known in communities in arts and culture and sports to thank people in Wales for following the rules. So this was about using social norming and rewarding positive behavior rather than trying to use scare tactics or be heavy-handed in the messaging. And if I move on to the next one, I wanted to show you very briefly the work that we pulled together around mitigating the negative impacts on well-being. And we talked, in terms of the 4 strategies, acknowledging hardship and addressing that. What we tried very early on to address and acknowledge that the mental aspects and the social cost to people. I think that my observation on that is that over time, I think what we see across all of our societies is that more people are affected more. So this campaign came quite early on in the pandemic, relatively speaking, but I think it was very powerful because we were tapping into the words on everybody's lips, which at the time was asking, like, how are you doing? And people really kind of wanting to look after each other. So we use that as an anchor to share a whole suite of messages and resources to support people or allow people to support themselves, enabling them to engage with the material and choose ways that were best for them. So if I move on to the next slide, we can skip across that one. That was just sort of another image showing how we developed and rolled the campaign out across all of our channels. So all of our digital channels, we did paid advertising, radio, etc. Slide 9, really quickly, just to kind of wrap up on the third campaign that I referenced, was around developing a suite of materials that just explain really specifically what the public health interventions are. And we felt that this was important for transparency and consistency, making sure that people could have an explanation for what we were asking them to do. One of the things that was really important is that we had to leave a lot of room for adaptation along with the situation. So we needed to have flexibility in the messages, but we retained a very, very high degree of consistency in terms of the branding and the voice, providing clarity and showing that we were always on and always there to provide the messaging that was appropriate at the time. So if I move on then to slide 10, what does that look like? What do those 3 campaigns look like at this juncture 1 year on? Well, interestingly, I think what we can say is that we've found the application of those 5 principles to be quite useful, so we're moving those forward. In January 2021, and I think, Kathleen, just for you to know, we prepared an advice paper and submitted that to Welsh Government, and the structure of that advice paper actually followed the framework of the 4 strategies that you set out, and we worked with our behaviour science team to put forward some advice to government about how here in Wales we could apply those strategies and bring them forward into some of the actions. So just to kind of reinforce how influential your work has been on that front. But back to our review, what does it look like 1 year on? We're continuing to deliver campaigns for our publics, but we're taking on new approaches and applying different and new resources with what we have now, which is a better understanding. So at this space and time, we have a better understanding of people's motivations and barriers, and we're working really hard to engage with people. And interestingly, we're coming back to some of the emotional messaging around thanking people for their continued commitment. And part of doing that is addressing the emotional aspects of information fatigue and behavior fatigue. So if I move on to the next slide, then I'm on slide 11. I wanted to share with you some of the things that we're doing now that are a little bit different than in the first half. So what we wanted to do is to really build on trust. And we know that the most trusted voices in terms of health information are health professionals. And so for that reason, we wanted to bring a really human face to the communications that we're pushing out. And I know there'll be a number of people on this call today who will recognize Dr. Giri Shankar at the very bottom. And we've pulled out that article. We managed to place a really long form profile of Giri into Wales Online, which has got quite a bit of coverage here in Wales. And the reason why we opted to do that was to really make the information more relatable, humanize our experts and the information that they're sharing to help build on that trust that people have in the public health experts and in health professionals. We really believe that recognizable faces making regular appearances and becoming well known build on that trust and provide that real consistent voice. And one of the things that's special about, you can see the top 3 examples there, Dr. Richard Roberts, Dr. Catherine Moore, and Dr. Shika D'Souza. The reason why we chose this particular aspect is because it demonstrates a fairness and a transparency element in addition to the consistency and the coordination. And what I mean by that is that we opened up our experts to answer questions from members of the public, and we chose to answer the difficult ones, the awkward ones, the questions from anti-vaxxers, you name it. And we wanted to make sure that by doing that, we were giving members of the public the opportunity to raise the issues that are important to them and ask questions that matter to them. And we also wanted to make sure that we were working in ways that allow diverse communities to feel that they're represented and feel that they can access information from people that they recognize. And I'll come on to the stakeholder work in just one second. So if I move on to the next slide, the stakeholder engagement piece has been increasingly important for us. So what we're working to do is develop a really strong two-way method of keeping engaged with various communities. And Hugh actually has been extremely involved in developing that and really building it out from our starting point back in February of 2020. In February of 2020, what we started with was just trying to rapidly get together some stakeholder lists and send information out and push information out to key groups just to make sure that they had it. And since then, what we've been able to do is to really recognize the multi-sectoral collaboration value, improve the stakeholder communications work, create two-way dialogue. So this is really about engagement and really just touching back on Katrine, what you talked about before around, you know, helping people to feel that they're in control, using local voices to disseminate messages because they are talking to their communities in a voice of trust. We develop new approaches. So I'm really proud. I'll show you on the next slide, actually, some of the easy share materials, the WhatsApp groups, tailored email updates that really reflect what the groups and people were asking for. We were pushing through on accessibility and really pushing and increasing the bar and the level of excellence in terms of people with sensory loss or other types of accessibility needs. Working with strategic partners to make sure that two-way feedback and putting public health messages out there is not just the Public Health Agency or the Public Health Institute in Wales, but actually it's members of communities where people recognize their peers or recognize their elders or their community leaders. So we were hoping today, and unfortunately the timing didn't work out, to come to be joined by somebody from Muslim Doctors Cymru, who we've been able to work with really closely in this most recent period, because we have a vested interest, shared interest in helping communities to stay safe from coronavirus. So if I move on to the next slide, I wanted to share this one because it shows you a picture on the left-hand side of the WhatsApp group that Hugh has been working to set up, which for the public sector is fairly innovative. So we know that people are on kind of dark social and working in spaces that we can't measure and access. So we felt that it was important for us to be able to create messages and information that communities and individuals could disseminate within their voice, within their communities. So again, again, this is about having safe and trusted messages and thinking about applying learnings. This is something that worked really well in the Zika outbreak in northern Brazil, and we took quite a lot of learnings from the case study around that piece of learning. So if you want to ask about that later or hear more, I'm happy to talk about that. We created a specific web page, you can see that in the middle at the back, where people can go and pick the information that they want to share on their social media and on their channels, enabling them to disseminate our messages more widely. And the item that you see on the front on the right hand side is the same thing. It's a Padlet, and it's a format that allows people to share and use and disseminate the signed off public health messages that we're creating, but doing it in a way that's really easy. And that was one of the things that was really important. You know, a really quick example of why listening to communities is important. From the very beginning, we got involved with networks and we were asking them what they needed. And clearly the virus having emerged from Wuhan, which is, you know, in China, we reached out to the Chinese community in Wales and became aware very quickly that whilst we were offering to translate materials into Mandarin, what the Chinese community told us is that we don't want to have it in Mandarin, thank you very much. Actually, we require this information in simplified Chinese, and they were even able to help us reach out to a specialist translator to get that work done. So it's just a really simple example about when you ask your communities and you get back really valuable two-way information. And of course, moving on to slide 14, you can see 4 wheels. I won't pause on this for too long because I want to get to my last slide, which I think is my, or second to last slide, is my killer slide, really. You know, of course, it was important on an ongoing basis to evaluate the work of the stakeholder engagement. So making sure that we're actually checking in and seeing if this work is helpful to people. My slide 15 for me is something I'm extremely proud of, and I sit here in Cardiff in my home office with this on my desk, and this is the Communicating Risk in Public Health Emergencies toolkit that was pulled together by the WHO and published in, I think it was 2015. And we use this as a document to guide our training and thinking about risk communications. And Giri and I were talking about it quite a lot before the pandemic, and we discussed it at one of the SHARP joint action meetings in 2019 as well. And one of the pieces of evidence in there is that if you can increase trust, that leads to an increased compliance with public health action and regulations. So that's why I shared this slide, because I feel like as a team, we've really reached the holy grail of risk communications and public health communications. So on the second line down, you can see that Public Health Wales has a trust rating of 72%, second only to health professionals who traditionally prior to the pandemic would have had a very high level of trust from the public. I don't think that many people in Wales would have necessarily known who Public Health Wales was before the pandemic. We're now very much under a lot of scrutiny in the public spotlight, but to have achieved a 72% of our population who were surveyed say that they trust the information that's coming from us is a real evidence point around what we're doing is working well, and we need to continue to build on that. So I guess that's my pitch, and kind of trying to show some ways in which we've applied the 5 cross-cutting principles in our work, and maybe some examples that you can feel free to ask about later. And my last slide really is about, well, what have I learned in the last 12 to 16 months? My big takeaways are we've been able to reach new audiences in ways that we never would have had the opportunity to do before. So I would always say never waste a good crisis. Going from 20,000 followers on Twitter to over 70,000, reaching over 250,000 members of our Facebook community groups, being able to, some of our Facebook posts were reaching in excess of 7 million people per post, which is shocking because our population is only 3.5 million in Wales. So I'm not, I think what this tells us is that we were telling a story and we were carrying a message that people wanted to hear. So it's not because we're such an amazing communications team, although we are. It's really the message there, the lesson is that we were carrying that message, and that's enabled us to grow our reach and our audiences. Through that, we've had to be extremely agile. So I've showed you quite a few examples of the work that we've done, and that's really only the tip of the iceberg. We've had to remain very, very agile, but alongside that, stay very consistent and transparent and predictable, and act with fairness. So I think for us, it's about making sure we capitalize on the opportunities as they come along and use the information and the insights that we get from our stakeholder networks. And finally, my little emoji with my smiley face and my 3 hearts, which is always for my team. So there are 30 of us that work on this in this division, and I'm ever so proud of the work that we continue to do in the face of COVID-19. So I'll leave it there, and I'm very happy to take questions either now or later.
Thank you, Leah. Again, really interesting, kind of really thorough overview of everything that's happened in the past year. It's hard to believe just how much has gone on in that time. Are there any questions? Any questions people have for Leah? I know we've gone slightly over in time, but we can make that back later on. Anybody have any questions or observations? No, we can always take a back around to again some questions later on in the final plenary session. Thank you so much, Leah. Yes, so going from those 5 cross-cutting principles, I'd now like to welcome Dr. Tanya Melillo and Dr. Shemaine Zara from the Ministry of Health Malta, who will be presenting on acknowledging hardships and barriers. Thank you, Shemaine and Tanya.
Hi, good morning, everybody.
Still getting a bit of feedback from you there, Tanya. But that's better.
Sorry, the phone. Good morning, everybody. Just to give you the background of how we've given our presentation. We in our country, we worked every case or all the cases we could contact, and our presentation is going to explain, what we faced when dealing with the different cases and the hardships and barriers that different people who were positive cases or their own contacts were facing, and how we tried to help.
UK, Tanya. I think you've lost it.
Sorry, having some technical difficulties.
I can share my screen again. I've got the presentation if you'd like me to do that.
The presentation is on. You want to come and speak from here? Come here.
Bear with us, everyone, or we'll just get some YouTube tools.
Do you mind if you click the slides for her?
Yeah, no worries. Let me just pull that up. There we go.
Okay, hello, hi. Can you see the presentation?
Yes.
So, I'm very sorry about this. Okay, so how do we manage cases in Malta? Basically, patients call the public health helpline, an appointment for the swab test is given, they do the swab test, the lab compiles the list of the positive cases, and then the case management team phone up the positive cases and a history is taken. And first of all, history is taken, and also to assess if they require hospitalization. So by history, I mean, apart from taking the symptoms, we also need to establish the contacts, so the social work and the household contacts. The contacts are then called by the contact tracing team to establish whether they need a 14-day mandatory quarantine according to established criteria. The follow-up team discharges the cases and controls on day 14 with a release letter. And very importantly, the general practitioners were there to follow those in quarantine and with symptoms. So far, to give you an idea, our first documented case was on the 7th of March of last year. Until yesterday, we worked a total number of 30,249 cases. So quarantine brought a number of issues, a number of hardships to various groups that we have identified here. So starting with the elderly, we encountered elderly who ended up on their own, either because their carer was hospitalized. There were also elderly who were unable to cook or get food, and others suffered from dementia. These elderly did not require hospitalization. However, we made sure that we check on them every day. So we called them every day, and we also had visits. They were visited by the ComCare community if they required medical assistance. So ComCare community is a nurse-based unit. Okay, so if they required insulin treatment, for instance. With regards to food, so either cooked food or else just food supplies were provided by several NGOs, all right, who delivered these at their doorstep. With others, we try to convince a family member to go live with them and quarantine, or else we found an alternative short-term living arrangement in a home until their carer returned. So moving on to children, so autistic children and those with challenging behaviors. There were special arrangements for these children during quarantine, basically to help the parents and also other family members. There were online sessions organized, okay, with their therapists, with their psychologists to help and occupy the child, all right, and also to help the family members. In severe cases, we had to find an alternative accommodation for the child with the help of NGOs. And in other instances, we sent carers wearing the personal protective equipment to the homes of these children to help the parents and other family members because they just couldn't deal with the situation alone. So moving on to cancer patients. We did not stop the treatment for these patients. We made special arrangements with the oncology hospital, the staff and their consultant. Very often we allow them to visit and receive treatment as the very last appointment for the day. What about tourists? Well, tourists planned a very short holiday in Malta, and usually one has an allocated budget to spend whilst traveling, but many ended up in quarantine. So they ended up with no money for food or accommodation. We immediately alerted the Malta Tourism Authority to provide accommodation, and again, NGOs helped us with the provision of food. What about third country nationals? Well, the main issues here were language barrier, lack of food, and usually these live in very, very large numbers in the same household, all right? Sometimes 7, 10, and even more in a single flat. We had difficulty to communicate with them, so we worked closely with interpreters to explain various measures like mandatory quarantine. Again, NGOs helped with the food when necessary, and the positive cases were transferred to a makeshift ward in a hospital to minimize spread. Moving on to migrants. Again, the main issue here was that they live in large numbers, okay, in the centers. We transferred the positive cases out of the centers to a place that was specifically set up for the cases and close contacts to quarantine. Red Cross was pivotal in all this. They provided the medical attention, and they were the ones who translated, helped with explaining what quarantine is and all that, very often using pictures. We also had issues related to these illegal migrants working here, and they were entitled to treatment in another member state, all right, like HIV treatment. So, moving on, COVID has shone the light on social issues. We had issues with domestic violence from an abusive partner. Very often it was against women. There were adolescents that were thrown out of the house by their families. when they resulted positive, and other persons who were homeless. What did we do? As much as possible, we kept regular contact with those being abused, and we intervened when required. With others, we helped them find alternative accommodation with friends or extended family or even shelters. So issues with pets, farm animals, horses and crops. Well, quarantine was a huge issue for dog owners, especially if they didn't have a garden or an outdoor area. We asked them to involve family members or someone they could trust as much as possible, and or else use a balcony or roof. If this was not available, NGOs were there to help. Quarantine also affected farmers, okay, with crops and farm animals. Again, as much as possible, we asked them to involve friends, families, colleagues, someone they could trust. If this was not possible, NGOs helped out, and the veterinary services helped take care of farm animals. With regards to horses, horse NGOs were involved to exercise the horses. As you can see on the slide, when it came to medical care, again, if the pet required a visit to the vet, we asked a friend or someone they could trust to take the animal to the vet. Else, NGOs were involved, and when it came to farm animals and horses, the government vets assisted. Mental health. A mental health crisis has emerged during this COVID pandemic. It was hard on all of us, I think, but cases and controls were finding it difficult to cope in quarantine. So we set up helplines, okay, so the Richmond Foundation Helpline. This is a non-profit organization that deals with mental health in the community. There was a helpline for the elderly, a crisis management team, and also online chat services. So how did people know where to call and what to do in case they needed help? We used a number of platforms. So very important is the weekly medical bulletin. This is held by Prof. Charmaine Gauci, the Superintendent of Public Health. There were a number of interviews with specialist doctors on TV and the radio. Social media, we set up a specific page on Facebook and Instagram. We also set up a specific page on the official website of the Ministry for Health. And also, when we initially contacted the cases and contacts, we made sure that we provided such information, okay, such as helplines and other advice and other resources they might use. All right, moving on. So we also identified barriers which hinder the implementation of public health measures. So starting off with the institutions. So the main issues here were lack of infection control training, lack of resources, and no planning. So we involved the Social Care Standards Authority. This is a regulatory body, and mainly they help with the training, the planning, and also testing. Okay, so random testing, random and regular testing for residents and also staff. So what about workplaces? Well, workplaces were not uncooperating and not implementing measures. For instance, they were telling them to lie to us when we called them. We sent health inspectors to these workplaces. They were closed when required, but very importantly, we educated them, okay? So we gave them advice on measures and quarantine. Obviously, we did this to safeguard the employees and customers. So this was also a barrier for us. It became very, very difficult to put people in quarantine. What was happening? So the people do a swab test, and obviously they were expecting a call. So they were not answering their phone, and they were basically lying about their contacts or places they've been. Some of us were telling us, I don't go out, I don't meet anyone, I don't have friends or family. There was also abusive language towards staff, okay, so all the teams, the case management, the contact tracing and the follow-up team. And at a point when we had a lot of cases, we were overwhelmed, and at a point we were unable to cope. We had a huge backlog. So this is my last slide, and I think a very important slide. We could not do it alone. The pandemic has hit us all. It affected us all. COVID brought many sufferings, but I believe this was a lesson for all of us in public health. We need to keep in mind every person, every group in our society, in our communities. We cannot work alone. Teamwork was very, very essential. We need a very strong network to help and lessen barriers and hardships. Thank you.
Thank you so much, Charmaine. That was a really thorough and really interesting insight into just a number of barriers. And I think it's really great how you took the opportunity of the engagement through the contact tracing to identify those barriers as well. You okay there? Can you hear me okay? Yeah, so are there any questions for either Charmaine or Tanya? It'd be interesting to see how you identified those different NGOs that you mentioned in the presentation there. Were they identified through the contacts themselves, or did you kind of take the insight from those contacts and then look yourselves at who you needed to be speaking with and who you needed to work with in partnership?
Really, it was work in progress. I mean, when problems were coming in, for example, the first farmer we had with his farm animals, so we realized, and so we got in touch with the veterinary department. We set up policies with them. So it was more along the way problems that we were finding. We then sought the NGOs, other ministries to help us along. I mean, initially, no, we had no idea we were going to find so many hardships and barriers that we would need to deal with when we're dealing with cases and contacts.
And were you able to share that workload of communicating those barriers between yourselves and those other organisations as well? Because it's hard to kind of capture everything at once. And I suppose working together, you kind of avoid duplication. Was that your experience?
No, once we set up the link, and then, like, for example, I mean, the first person we had who told you does, he takes care of 3 horses, and we knew, you couldn't leave them not being fed, not doing exercise. So the first thing we did was get in touch with NGOs we know who are responsible of taking care of horses, and we got them on board, and sort of then once we made the contact and we set up the engagement between them and how they can help us and we can help them, sort of then for the next person that came with the same issue, we could and then use the same people. So it became easier as time passed.
Yeah, well, thank you both so much. It was a really interesting presentation. There's some really valuable insights in there, I think, as well. If there aren't any other questions, I'm going to give it a second to see if anyone comes through with anything quickly. But if not, what we're going to do now, before we take a short comfort break, I just wanted to do a bit of an interactive session with everybody. And it was just an opportunity to go back to the 10 suggested actions or kind of recommendations that are laid out in the COVID-19 fatigue framework. So I'm just going to post a link in the chat to a Mentee Meter presentation. It's just 2 very short slides. If people want to click on that link there, it should take you straight through. And what it is, it's just a sliding scale of just self-reflection, really. It's all anonymous. We won't see what your individual responses are, but it's just an opportunity to reflect on how you think yourself, your institute or your country have responded in these specific areas. So thinking about how have you thought local, how have you reached out to civil society groups, and so just measuring that on a scale of, if you think you've done it very, very well, so excellent. We've done it okay, but there's a bit more room for improvement. So good. If you think you're kind of satisfactory, so you're kind of middle ground, or if you'd like to see, more improvement or a lot more improvement in some of these particular areas. So if you click through to the Mentee Meter, you've got it's just two very short slides. You've got 5 on each page. So thinking local and reaching out to civil society groups, asking users to determine the delivery of the rules. So Katrine gave that really great example of, asking school children what they think the rules should be. Going along those lines, and it's something we've certainly done in terms of, engaging specific groups, and I'll go on to that in my presentation on Ramadan as a timely example. Guidance for everyday life. So, what are those how are you communicating the guidance that can help people just go shopping, go around into different areas? And how do you prepare for big events and cultural celebrations? And how do you balance short and long-term bearability? Leah, did you have a question before I go on to the next slide?
Yeah, it was just while people are thinking about their answers, it was really just an observation from me, really. I just wanted to say how helpful I found the framework itself, especially after, I think we spent a lot of time, many of us just learning very quickly as we go, and with some struggles and some challenges, as you would expect. And I just found that the framework, when it was published, provided a very, very clear way to frame and structure both activity in terms of developing support for restrictive regulations, but also protective behaviors and how they can be applied, but also for how we structure our communication. So it was really just to share that observation on how helpful I found it.
Oh, thank you, Leah. So for those that have just joined, we're just doing a very short self-reflection interactive session, looking at some of the recommendations and the suggested actions set out in the COVID-19 fatigue framework. So if you click on the link in the chat there to mentee.com, it's a sliding scale of going from needs a lot of improvement through to excellent. So needs a lot of improvement, needs improvement, satisfactory, good, and excellent. So it's kind of asking how either you as an individual, your organisation, or your country as a whole have responded in these respective areas. So if you click on the link there, and it'll just let you slide across, and it's all anonymous as well. So I'll give it another second before I go on to the next page. But yeah, just to support what Leah has said, those kind of principles and the framework, it's clear. I think what it's clear from both of the presentations so far is that collaboration, it's that approach fosters collaboration and nurtures it in a very healthy and sustainable way, which is really interesting. And if anyone has any other takes that they'd like to come in with while we do this exercise, please do.
Right, so Megan's asking, was it shared? And Megan, the framework is on the WHO website.
Okay, I've missed it, obviously, completely and entirely. My life is COVID, so I've obviously missed that there's a fatigue framework somewhere. So yeah, I saw this come up and thought, oh, I'll join this meeting because I'm fatigued by COVID, because it's my life 24/7 at the moment. But yeah, no, that's fine. I'll go and have a look. I've obviously missed something.
And Megan, I don't know if you joined from the beginning and if you heard me say that the advice paper that we submitted in January that I worked on with Ashley Gould and Giri Shankar was structured around the 4 strategies within the framework as well, and that is reflected in the risk communications subgroup of the technical advisory group.
We don't get those papers in those of us that are in the regions actually responding to COVID and dealing with what comes out. We get the byproducts, but we don't actually get fed all the paperwork from those technical advisory groups. Even though I sit on the contact tracing regional group and I sit on the TTP program board, miss all of those.
Yeah, well, the advice notes are sent directly into the CMO. That's why you don't get them.
Yeah, so it would be nice if at some point there's a loop where those of us on the ground reacting also get this information. It'd be really helpful. Great.
Okay, well, we can absolutely take that back to the people that sit on the advisory committees. Thank you.
Thank you both. So just to talk through the second slide then, so the next kind of areas for some self-reflection are achievable and affordable behaviours. So are some of the alternatives to what people would usually be doing cost effective? Can people afford to do what you're suggesting? Do they find it achievable? Appealing to people rather than blaming. Again, so it's making sure that, you know, as Leah mentioned in the presentation, it was about appealing to their nature as opposed to saying you shouldn't, you know, blaming them, you shouldn't be doing this, or oh, you don't do that. It's kind of, you know, you could do this, and appealing to that kind of sense of that kind of sentiment, really. Clear and precise and predictable. So how clear is the information? How regular is it? Do people know where to go or what they need to do? Being very clear and precise in that. Population studies. So after a short break, Annalena will be presenting on some of the population data and how they've analysed that and how that influenced their communications and their approach to COVID-19 fatigue and communications as a whole. And then tailoring communications to specific groups. Again, in the afternoon session, I'll be talking through some of the work we've done around Ramadan, supporting the Muslim community in Wales. So again, just self-reflection opportunity here. You know, what do you think needs a lot of improvement? What do you think could be improved? You're finding what you're doing satisfactory, but there's room for improvement still. And you know, were you delivering at an excellent level? What do you think you really nailed as well? You know, I think it's important. You know, we've been all working really hard over the past year. Shout about what you're doing. You know, take pride in the work that you're doing, as Leah mentioned. You know, there's been a lot of innovation over the past year, and it's important to celebrate that as well and take pride in it. So I'll give a couple more minutes just to fill this out. And again, while we give a bit of time for people to fill this out, if anyone wants to come in with any reflections or thoughts from the morning session so far, please do feel free to raise a hand or come in.
Hugh, I see that John has his hand up.
Oh, sorry, missed that.
No worries,
John. John, if you'd like to come in.
Thanks. Yes, this is John Kingsman in ECDC. A very interesting presentation. Thanks very much indeed. One of the things that I have been thinking about and wondering about is if anybody has come up, the 10 points here are all, I completely endorse them and everything like that, but I'm just wondering if anybody has come up with or has been working with any of the sort of established behavioural change theories or models to help to actually formulate how to go about this, and hence my question about fear and perceived risk, because I've been thinking about the health belief model as a way to frame some of what we've been trying to do, and obviously it's a very individualistic model, but it talks about perceived susceptibility, perceived severity of the disease and so on, which I think is probably a useful construct or useful constructs to be thinking about. But I don't think that this takes into account enough of the structural issues, and I don't think it takes into account the fact that many people are engaging and adhering to the NPIs out of solidarity and out of a wish to protect others. So I'm just wondering if anybody else in this call has come across or has been using any sort of theoretical model which actually embraces the range of constructs and issues that actually determine whether or not somebody adheres to the measures or not. Thanks very much. Over.
Thanks, John. I can certainly, speak from our experience at Public Health Wales and in relation to the How Are You Doing campaign in particular. We applied the Combi model for behaviour change to a lot of our communications. We worked very closely with our behaviour change unit in developing messages for the campaign, and it was in making sure that that approach was a part of that kind of process of developing the campaign itself as well. So we gathered the insight, we got, we set up population data survey as well, similar to kind of what Annalena will be discussing, but we got the insights from that. We then took that to the behavioural science team and we used that kind of combined approach to actually develop some of the messaging. And actually we're at this later stage now where what we're also looking to do is work with some linguistic specialists to actually analyze if the wording that we're using in these messages is also effective in delivering that behaviour change mechanism. So it's, again, now we're at this later stage, which is quite crucial, but kind of less intense. We have that opportunity to really kind of hone in and really make it the most effective that it can be as well. I did see that somebody else raised a hand. I don't know if it's still up. If anyone else wanted to come in quickly before the break.
Jonna, it's Leah here. Hugh, it's just a flag, within, it'd be really great to hear from what others have been doing, and Katrina has talked about COMBI as well. We used the EAST framework in developing the messaging for the How Are You Doing campaign, and that's quite a specific example, but I think it's much earlier on in the pandemic, so it doesn't really address the specific question that you're asking around how are things adapting now to the behavioral insight. But using audience insight and using the information that we're gathering from what people are doing, both behaviorally and how they're responding to the messages, provides a continuous feedback loop for us as a communications team, so that insight is really core to the starting point. And another piece of really valuable insight that's coming out that I'm hoping will drive some behavior change in the way that we deliver, when I say we, I mean Wales, delivers the contact tracing and support to people who've been contacted, is the work that the research and development team are doing, led by Alicia Davis and Richard Kyle, looking specifically at acts and cabins, where they're surveying people who've been contacted as positive cases and asked to isolate, and they're working through quantitative survey analysis to understand those barriers more specifically. And some of the recommendations that come out are very behaviorally based. So they're finding differences in societal cohorts between people with dogs in different socioeconomic groups, responding differently to the ask to self-isolate, for example. So people in lower socioeconomic groups are more likely to comply with self-isolation when they have dogs, whereas people in higher socioeconomic groups are less likely to comply. So there's some specific takeaways in terms of how people are given instructions to self-isolate and comply with rules. So I mean, that's just one example, but there are some more specific ones that are coming out of that work, which are quite specific to our population.
Thanks, Leah. So we are kind of in the schedule. We are kind of going to take a very short break now for those of us who have been on the call for most part of the morning. So good afternoon and welcome back to the Sharp COVID-19 Fatigue webinar. To launch this afternoon's session, I'd like to welcome Anna-Lena Loheniva from the Finnish Institute for Health to present on monitoring risk perception of the public. Thank you. Over to you, Anna-Lena.
Okay, so thank you very much.
So Anna-Lee, you might want to just move me out of the way. Do you want to say me?
Yeah. All right. Yeah. So I will be talking about our risk perception monitoring process that we have been running here in THL since February 2020. The aim of this process was to understand the perceptions of the public towards various issues related to the pandemic. So this is a practical process that is based on collecting social media data, analyzing it, and then drafting risk communication recommendations on regular basis. So basically, it is a tool for risk communication for them to draft messages and content meaningfully during the pandemic. And before I move on, I would like also to acknowledge my colleagues, Katja Siebenberg and Suvi Hyökki, who have been very closely also working on this process. When we started to develop the process, there were certain steps that we had to think very carefully. We were thinking about this data retrieval system. We had to first think which are these channels that the public is communicating with us, what kind of social media channels they are using mostly, where the most beneficial information is coming from. We decided then to use the Facebook and some contents of info email boxes as a content for the process. We also had to think about how we want to analyze the data which is coming up, And because we really wanted to understand the public, so we thought of using qualitative analysis as a base for this process. And then we also had to think about recommendations. How do we draft our recommendations for that risk communication? And I think this links perhaps with John's earlier question, asking what kind of framework for change or behavior change should we think or would be best. We did not take any specific framework for change for the drafting, but rather decided to apply very openly risk communication principles and behavior science principles on drafting the communication. Partly because we did not want to lock ourselves into certain framework, and also because the whole thing was new, and I think we were sitting and thinking similarly as also what would be the best framework. So that issue was left open. However, I believe that the more we carry out these frameworks and these processes, the more information we get out of this, and perhaps also at some point we are able to establish our own behavior change model based on this process. But at this point, it's really has been open discussions. And in our reporting and dissemination of the findings, we also included knowledge co-creation. So we wanted to have an opportunity to verify and reflect the analysis and as well as the risk communication recommendations before they come up in the final format as recommendations for the process. And if we think back, or if we think what this framework did as a change, is that before we had this monitoring process, the social media data, the information, the communications of the public were coming to us, and public health experts and risk communication experts used this information individually. So they created their own understanding and interpretations of the data and used it as such. And then at the moment, we are pulling this information together, we are analyzing it, and it comes out as one report. So definitely this type of information is now more readily available in the organization. It is probably much more used because it's easy to use if needed. And perhaps also and to some extent, it has also unified the messaging that is coming out from our organization. Just as a principle, what was kind of driving this idea was really the need to develop context-specific communication. As I think we have also mentioned in several presentations, the need to understand the perceptions of health and illness and healthcare are very important when we want to really address the behaviors and the overall understanding and draft really meaningful communication. And these perceptions and ideas are also changing in time. So as we come along with the pandemic, of course, things are also changing. But some of these factors that are extremely important, I think, in this pandemic, we're talking about differences in risk-taking practices or physical distance taking, greetings, hygiene behaviors. When we talk normative rules, it's also very important to understand how the public is perceiving the instructions of the authorities, where we are talking about a trust, what kind of things are currently trending that are building the trust, what kind of factors we can see that are influencing the mistrust. Individualism and collectivism are also very important issues to be captured. What is really motivating currently the behavior? Are the current narratives looking into individual factors? People care about their own health, or are they perhaps discussing larger issues influencing the whole society? Are people interested in what is happening to the nation, or do they care more about their families? And overall motivation, as we all know, behaviors do not change or stay the same with this information, and fatigue that we are, and you have been referring several times, of course, has a big role or is strongly related to the issues of motivation. What is motivating those different behaviors that we need to promote to the public? And the second overarching important issue that we also thought of when creating this framework was really to enhancing the understanding and acknowledging the fact that it's really not a very simple thing to communicate to the public when we talk about expert information transfer to the public that is usually looking into the understanding very differently than experts. Experts like to talk about the evidence, they like to talk about the data and information, whereas citizens are then thinking more and filtering this information through experiences and emotions. So somehow we also thought that having this kind of framework will also allow us to build this bridge between the health authority communications to the citizens and ensure that we have less misunderstandings along the line. Now, I'll give you a few examples. There are 3 examples actually that I have collected to show how this framework has practically worked. As I explained, we try to do it simple, and we have been trying to do it continuously. So at some point we had even a bi-monthly analysis. Lately, we have been doing them less, perhaps once a month, but depending really on the available resources. So this is one of the data analysis that showed us that people had a lot of questions how to manage their everyday life. What can they do when they go at work not to get infected with corona? Or what should they do when they take public transportation? And what is the best way to deal with when you are in a shop that is crowded? So it was clear that people had difficulties to apply these new information about social distancing in their everyday life. So we decided that we would need to develop or deliver provision of practical guidance for people how to prevent infection in everyday life. We came up with the application of a methodology for personal risk assessment that we decided to deliver through some social media influencers. So we created a webinar where we introduced this idea of personal risk. We asked these influencers to list all the risks that they had from the morning to the evening in their lives. And then we asked them to brainstorm how they can reduce those risks. So, for example, if they felt like buying groceries was a very big risk factor, they could, for example, think of getting the groceries delivered online. Or if they thought that using elevator every day was a risk factor, then perhaps the suggestion was to use the elevator and so on. And after this exercise, we also encouraged them to share the same framework and the same methodology with the followers and requested them to carry on the same system among them. The second data example that I have here was about the data where people were really wondering if it mattered what they were doing. There were a lot of questions and a lot of questioning, like where is the real evidence that, for example, mask use is effective, or why should I actually, refrain meeting my friends? Is it really going to be a big deal if I do that? So there was a clear disbelief regarding the effectiveness of these measures. We decided that there is a need to concretize the transmission change to actually show how easily this virus can transmit and how effective it is actually in that case to do what authorities are asking them to do. So we created a real story, or it's a real virus transmission story that we displayed on the video clip. and which was then distributed through our social media channels. My third example is a data set where people looked into other people thinking that they are alone doing what they are doing, meaning I am using the mask, but my friends no longer use that. People go around and they don't care about social distancing measures anymore. I'm the only one who is doing it. And how does it help if there's nobody else following these rules? So kind of the feeling people felt being alone, and they thought that that there is no one else anymore doing the things, that these behaviors are no longer a norm in a society. The positive thing about this data was that it showed that the idea of each individual and the behavior of each individual matters was very positive, because many of the campaigns in Finland have been stressing strongly the importance of the behavior of each individual. But now there was a clear need to emphasize the fact that people were still doing this. And this is actually very similar to the campaign that Wales had been doing also earlier, meaning bringing positive examples of role models actually on the table to show people that they were not alone, and also to bring positive messaging to emphasize and to manage to carry on a bit longer with all these restrictions. So those were basically the examples that I had about this process that we have been doing so now over a year. And of course, we have many lessons that we have learned already. And definitely the process of developing this process is still in a process. So we are all the time learning and also improving it as we go along. What we have definitely learned is that we can use this kind of framework, and we can get very specific, context-specific and culturally appropriate recommendations out of it. And we also learned that the way we are doing it without any heavy structure, we don't have a working group that meets regularly or anything. So this lightness of this process has kept it alive, despite of the fact that everybody is extremely busy during pandemic, and not many people have a lot of time to hold on it. But it has been made as easy as possible, including also the dissemination of the research findings that is usually come through a PowerPoint, which is as short and as point to as possible, and also with some Teams-based meetings that people can join if they have a time and interest. What we have, however, also learned is that the process requires time and resources. So to do such a process, there has to be someone who can, for example, analyze qualitative data. There also has to be people who understand some basics of behavioral sciences and risk communication. And it is also, in the end of the day, quite labor intensive. So some automation might actually increase and make this process even better. We all know that the area that we think is very beneficial, reflecting the findings, is still quite limited because people are busy. And also, we don't know exactly how much and how these findings are used in the reality, because we don't have any real monitoring system currently in place. So we learn on ad hoc basis how the results are used. So those perhaps some of the ideas that we still want to continue working and developing in the future. And we are also at this moment planning to expand the very same methodology and introduce it to some other entities. We're going to build some capacity building framework to capacity building workshops to carry out and let other entities to benefit from this as well in Finland. So thank you.
Wonderful. Thank you so much, Annalie. That was a really great and really interesting presentation with lots of great insights. I was particularly, captured by that approach to asking influencers to think about the risks that they identify, from morning, day, afternoon, and evening. I think that's a really smart approach in terms of, getting younger people and influencers to think about those various points throughout the day. So it's not just tackling one behaviour at a time; it's getting them to think about, not in a kind of a scary way, but the constant kind of risks that are around them, and being able to identify that is a really important part of changing behaviour. How were you able to kind of tailor some communications from some of those specific insights?
I don't think we have done, but I might be also wrong. We haven't really used the risk perception framework for further refine any messages. I mean, it was really I think the overall idea is that we can never get rid of all the risks that we have, but we can try to minimize them. And we all have our own context, and we can, what we can do is we can do in our own context. And I think it was like kind of a wake up and think what I can do really in my own everyday life.
Yeah, that's really great. Any other questions? Feel free to drop them in the chat or just raise your hands. So Leah's put something in there. Can you talk to us a bit more about the interconnected process? Your slide showing data through to message development was really helpful. Something we've been trying to do and gain buy-in to in Wales as well.
Okay, so I think the interconnected, what you mean is the way that we are drafting the risk communication messages coming out of the data. Is that correct? I assume this is the question.
Yes, and also just how you got your teams, like, is that the way that your teams were already working, going from data collection through to analysis, coming up with the concept that needed to be addressed, then through to messaging, or did you have to create that through the pandemic, the ways of working?
No, there wasn't such a project before. So basically people, experts from the organization that are already working actually in the risk communication joined these efforts to do the work. We actually have published this methodology in Eurosurveillance last year. So you can actually also find more insights to the actual methodology, how we were doing it. But as I was trying to explain earlier, the drafting of the messages is really based on basic brainstorming, basic risk communication principles, and some basics for behavioral sciences. So we don't have this behavior change framework that we would be directly using to come up with these recommendations. But as I said, I think we hope to come up perhaps with some kind of actual conceptual framework at some point. The more we do, the more we get insights into it. The qualitative data collection then was based on a thematic frame analysis. So we have a rapid thematic analysis that we are conducting using NVivo software to analyze them. So I hope that answered my question.
Yeah, absolutely. I also I love how you described how you made it a really light, agile process rather than putting a lot of, big program governance around it. It was more about, getting things done. And also I love the idea of having your data outputs and your findings consolidated into a very concise kind of PowerPoint type message, because sometimes it's really hard for those of us who are not researchers to distill what we need to know from a long report, and it's part of what we do, but it's helpful, so thank you.
Great. Thank you so much, Annalena. I really appreciate you taking the time to present that to us. So we're now going into the final presentation before we go into the plenary session. And I'm sorry you've heard a lot from me already today, so I'm going to try and keep it brief. I'll be talking about living lives while reducing risks, and I thought what would be really useful is to go through a really timely example around Ramadan, which is currently running at the moment. So it's a holy month running from the 12th of April to the 12th of May. So just wanted to kind of really talk through the process really of how we got to doing what we did to support Muslim people across Wales to celebrate safely. So I'm just going to share my screen. Going to presentation mode. Just checking, can everybody see that okay?
Yes, thanks, Hugh.
Brilliant, thank you so much for that. Okay, so as I said, I'm just going to kind of do a very kind of brief talk through what we did to approach Ramadan and make sure that people could celebrate and practice Ramadan in the safest way possible. So what I'll be covering in this session is, where did we start, who was involved, what was needed, how did we deliver that, and then also kind of touching on why is it important, and then kind of how do we kind of expand on this work and the progress that we've made and the relationships that we've built. And again, linking that back to the framework, it's really making sure that we help the public differentiate between the high and low risks in celebrating Ramadan, helping develop the guidance or communicating the guidance on how to celebrate safely. I mean, given a really consideration, about the cultural events, and we've worked with various partners, which I'll kind of touch upon as well, and then encouraging individuals and communities to identify harm reduction strategies as well, and how we communicate that effectively. And kind of, as has been discussed today, it's shifting that message from do not to do differently. I think at this later stage in the pandemic as well, we've got the added bonus of being able to say, well, we've done this before, we can do it again. And again, I will expand upon that shortly. So where did we start? Well, we knew Ramadan was fast approaching, and we knew that compared to the previous year, we needed to be more proactive. And we also knew that we had more resources and more time and capacity to be able to be more proactive as well. So if you think back to Ramadan this time last year, the pandemic, we were still very much in response mode and react mode. Everything was very busy, so there wasn't that capacity. And if we're honest, we weren't at that place where we were able to fully support in terms of having that cultural awareness and those relationships, which we've now developed since then. So we're now in a place where we can work more collaboratively. And we very much saw our role as a supporting one, helping to reinforce some of the key messages in relation to guidance and in relation to vaccination during Ramadan. And this approach very much fitted in with our current way of working. And so the makeup of our communications team at the moment, we have a business as usual cell, and then we have a COVID-19 cell, and these two kind of very distinct teams. They do work very collaboratively as well, and there is crossover between the two. But this approach to Ramadan itself fitted with the ways that we were currently working, which was really important as well. But what was already happening, and who was already involved in this? Well, Muslim Doctors Cymru, which is a great group that we started to work with, were already producing a number of assets in various languages and formats. And this is a group of doctors from Wales who just banded together to form this group, and they realised that, their trusted voices were really important in this and getting information to the community. The British Islamic Medical Association was also working very closely with Public Health England and the Welsh Government to produce guidance that was in line with Islamic scholars and Islamic teachings. So it was making sure that there was this multifaceted and multi-pronged approach to making sure that we were providing the guidance in a way that was doable on that kind of practical level. And what was needed to be able to communicate this? Well, our partners were already doing a lot of the work. They were delivering messages from health professionals that represent the community in the languages that are spoken by that community. So again, Muslim Doctors Cymru have a number of members across Wales who speak various languages, and being able to deliver key information and messages in that language of the community. It removes that barrier and it makes it that bit more accessible. And they were putting those across various channels. They were also creating spaces designed specifically for those communities where they could answer community specific questions, and again in a language from that community. And they were also already producing guidance, and they'd created a web page with a wealth of resources and advice, all supported by Islamic scholars. And that was really important to get the buy-in from that religious community, because it's all good us as a health body saying things, but there needs to be that clear understanding and a cultural frame of reference in terms of Islam, and being able to understand the needs of that community and how that affects religious practices. And so it's important that we weren't trying to replicate it, but we were trying to enhance it with the tools that we have available as well. And that was very much the route that we ended up going down. So how did we support? And I know Lee has previously talked about some of the platforms that we've developed. But it was very much a discussion, and we met Muslim Doctors Cymru on one of our vaccine engagement boards set up by chaired by Welsh Government and my colleague Hannah Lindsay in our vaccine communications team. And in that engagement, I think we'd gone along to present on one of our WhatsApp communications channels, which was the new channel that we set up, and Muslim Doctors Cymru had come along to share some information about some of the audience insight and data they had gathered. And it was at that meeting where we made that connection, and we realised that actually we had two different parts of the puzzle that we could piece together to really make sure we could work in co-production to serve the same community, to serve our shared audience. So what did they need from us? Well, we talk a lot about equity, and I think part of equity is raising others' voices, not just relying on our own. And we were in a position to raise our partners' voices via our platforms. They had the knowledge of Ramadan, of the religious practices. They had the links with the local imams across the country. They had the languages and they had the resources there. But what they didn't have was the platforms that we have, the sheer numbers and volume that we have. They didn't have the formal communications set up. They're a team of volunteers, and they didn't have the editing software to be able to, co-brand materials. So we were really able to add value. And again, identifying that not everything necessarily has to come for us. Sometimes it is about raising your partner's voices and using those trusted voices in the communities to deliver that message. And, I think the success we've had with some of the Ramadan communications is really a testament to that. So, we were able to co-produce materials. As Leah mentioned earlier, we set up an easy share resource page. Well, actually on that page we have the recite me function, which allows you to translate the page into various languages. There are hundreds of languages on there, and I think about 44 of them can also apply screen read technology, and it will read that language on the page. And what that enabled our Muslim audiences to do was to be able to access this page, copy and translate the page into the relevant language, and then share that message with that community in their own language, which again was something they didn't have the time or resource to be able to do. We were able to use our newly established WhatsApp distribution list to get those messages directly to the community. And we were talking about stakeholder engagement earlier. The WhatsApp messaging distribution list was very much an amalgamation of a series of feedback from our stakeholders. So we'd initially started with a very clunky version of the Easy Share resource that you see here. And feedback again from the stakeholders was that actually, we don't have a formal communications setup. We don't have the materials, the assets, the capacity. So we need this in a much easier format. So then we thought, well, why don't we just send them the WhatsApp messages directly, and then they can forward it on? And that has given us a whole new, a more timely approach to being able to do this. We can be more reactive. Just this morning I got a WhatsApp from Imad from Muslim Doctors Cymru saying, oh, we've got this. We've got a pop-up vaccination station in one of the mosques this weekend. Can you help communicate that? We can be very reactive and very quick in response in that respect. Similarly, using our Padlet that we set up, where our partners and our stakeholders can access information. And again, it's not just the information for organisations working with Muslim communities, so it's not just tailoring this to Muslim Doctors Cymru, to the Welsh Muslim Council. Actually, if we think about the NHS across Wales, if we think about our local authorities, our local public health teams, they can now access, and our staff as well, they can now access these resources, and they can be ambassadors for equity and kind of creating that equitable approach to guidance and COVID safety measures. So it was really important that we could deliver that. And like I said before, it's about piecing that puzzle together. We had one part of the puzzle, they had the other, and now we've been able to create a really unique and bespoke experience for our Muslim community in Wales. Again, how this links back to the framework and strategies, it's encouraging individuals and communities to identify the harm reduction measures. And it's again shifting from that do not messages to the do differently, and using trusted voices to deliver that messaging as well. And just to kind of go over why this is important, well, linking back to some of those 5 cross-cutting principles, it's about fairness. And it's about health equity. It's about making sure that a community that's already at increased risk of coronavirus and is already experiencing health inequalities is receiving kind of information in an equitable way. It's about us proactively putting ourselves out there and reaching out to that communities. We often describe Black, Asian and minority ethnic communities as hard to reach. They're not hard to reach, it's just that we need to proactively step into those spaces as opposed to expecting them to come to us. And again, this is where a lot of this work came from. It was, we were getting feedback from stakeholders that our audience don't come to your website, they're not on your social media channels. So it's about proactively placing the messages in those communities. And it's about building relationships as well. We've started a fantastic relationship with Muslim Doctors Cymru now, and now that's a relationship that we can actually develop beyond the response that, again, is going to continue to benefit that community beyond coronavirus and actually allow us to rebuild. And a phrase that typically is quite often used is building back better. We've established this relationship now, so we can take this forward. It's about, again, leading by example and making sure that we can set the standard for engagement with different communities and set the standard and encouraging other people to meet that standard as well. So making sure that we're encouraging Welsh Government, who have also adopted some of our easy share messaging, making sure that we encourage our local authority teams and our local public health teams to take some of these practices on board as well. So just to summarise, and I did say it was going to be a very quick overview. We started by thinking, what is happening, when is it happening, where and why. You then need to start thinking about who is involved and what are they already doing. And when you've thought about that, you can then start to think about what your role is as a public health institute. Is it amplifying messages? Is it replicating? Because there's good replication, there's bad replication, and you don't want to duplicate efforts that will possibly confuse the messaging even more. You then, once you start to kind of iron some of that out, you can start to think about how you collaborate together and how you can deliver this collaboratively, and then thinking about, once you've established that way of working, where you're going to take it, what other areas may benefit from it. Is it screening services for other diseases, conditions? Is it communicating other public health measures? Is it communicating your work as an organisation? Once you start to develop this relationship, you've got an opportunity to really build something unique and, again, tailoring messages to that community. So that, again, that was a very brief overview of the work that we've done around Ramadan, and I can link in our Padlet if you'd like to see some of the materials that have been produced from that as well. But yes, I'm going to stop presenting now, and if you do have any questions, I've not been able to see the chat while I've been speaking, so please do either raise a hand, shout out, or drop something in the chat.
I think Fanny's got a
Yeah.
Okay, now I got the microphone on. So put the video on so you can see. Thank you. It was a very interesting example. I can hear my voice from the background. Maybe someone has their mic on. You can hear me okay?
Yeah.
Okay, great. It was really interesting to hear your presentation. I think this is very relevant to every country in Europe, so it was very nice that you were able to present that. If you have some materials, I think it would be interesting to see them, so just link them in the Padlet if you have something you'd like to share. I think it's really, especially what you said about, it really resonated with me when you said that sometimes it's okay to have the other organization or group share the message. It's not about who says it, it's about who will hear it and really understand it. So I think that's a very important message. Thanks.
Absolutely, thank you very much. And when we think about in public health, we often talk about partnerships for well-being and how we work with other groups, NGOs, local public health teams, and a range of stakeholders to design interventions and more kind of practical interventions. But actually, that's a principle that we can apply to risk communications. And throughout the pandemic, I think it's proven that that approach is really effective in reducing some of those inequalities in health information, particularly in specific communities. So Ramadan was a very timely example, but Leah touched upon some of the other examples that we've done through our approaches, certainly throughout the pandemic. So it's a really interesting approach to kind of, I think a lot more work and development could go on with that as well. And absolutely, as Leah said, the travellers community is another community often described as hard to reach, particularly if we talk about issues of trust in kind of more authoritative bodies or official bodies. There are barriers of trust in, and again, it's that communication that's really important in breaking down some of those barriers. So yeah, that's it for our presentation so far today. And what we're looking to do now is just sort of kind of open the questions back to the floor, really. So we've still got a number of our speakers still here, and I'm sure if you have any specific questions about their presentations, they'll be more than happy to answer them. But I thought, in order to kick off the session, following on from the Mentee Meter and the interactive session that we did just before the break, I just wanted to kind of, maybe start off with some of the indicators that kind of came from that, really. I will share my screen again very briefly, just so I can get those results up for you. So I will share that now, screen 2. Can everybody see the Mentee Meter results?
Yes, I can see them.
So, if we started maybe with some of, the lower scoring areas, so 2 of the lowest scoring, they are the asking users to determine delivery of rules, and the other one was, just check on the other page, and balancing long and short-term bearability. Does anyone have any particular thoughts around potential barriers to why they are scoring slightly lower than some of the others? So I think, from some of the presentations, we've seen some really good examples of actually asking users about their understanding of the rules, about identifying risks. So it's interesting that it's scored a little bit lower, despite there being some really good work going on in this area. Or perhaps it's a little bit easy to maybe start with some of the more positive ones then, in that case, if there are no questions in regards to that. So I think, guidance for the everyday scored quite well, and also appealing to people rather than kind of that blaming approach. Does anybody on the call have any particular experiences of maybe delivering some of that messaging, or have any, some of their thoughts about how they've delivered that well or struggled with aspects of that?
I noticed we had a couple of joiners from RKI in Germany, and not to pick on anyone, but I just wondered if we might want to, I know we've heard from Malta and Finland, and maybe, I don't know if Sandra is still with us, if maybe she can share some of her perceptions about the situation there, or if anyone else wants to kind of chip in and join with their experience of things. Everybody's very shy today.
Repeat what you wanted to from our end, our experiences. Can you repeat again the question?
I suppose it was just in regards to, we started off with talking about some of the 10 recommendations and, everyday guidance and kind of appealing to people rather than blaming them. And I know you kind of already presented on understanding barriers through the contact tracing, but how is this translated maybe into some of those other areas?
No, definitely not blaming them. I mean, these were people who were suffering. I mean, a lot of people were suffering. I mean, they had genuine concerns regarding their own family members who were, found they couldn't continue with their daily life of taking care of an elderly person, or like we said, even people who are responsible for farm animals. So it was really much the suffering people face, and as I think public health doctors, I mean, it made it clear to us that we had to go far beyond sort of our job in public health, being physicians and just seeing the physical side, the physical ailments of patients. We had to see it holistically. We really had to help them with their social issues, because they were affecting them, even more, I would say, because many of these were people who could stay at home because, they either had mild symptoms or no symptoms, or they were just contacts. But the disruption to their lives, like when we had a person who was the carer of other people in the home who ended up in hospital. I mean, these were elderly people who were totally dependent on others and found themselves totally at home on their own, and even with NGOs involved, I mean, they have their limitations too. And remember, there were times when there were lockdowns, and there were times where so it wasn't easy. And I would say till today, we're still facing more the social issues. I mean, it's easy to say that's not my problem, but it wasn't something we could do. And I think this is something that we have to keep in mind, that it's more than just people falling ill, that there are other aspects to the whole equation that we have to factor in.
Tanya, it sounds like the state healthcare system in Malta had to take on roles and activities that it never did before. That's what you're describing. So
exactly.
Yeah.
Exactly, very much so. We got the other people on board, but like I said, sometimes with lockdowns like that, I mean, we had to sort of do it ourselves, and we felt responsible of these people. Once sort of you phone a person and you tell him you are positive, you need to stay at home, your family stay at home, you sort of became responsible of that family, and anything that happened, they would turn back to you, and everybody wants, give me your phone, give me your email, so if I'm really in dire straits, they wanted to have that lifeline, that if things really got bad, there was going to be someone somewhere who could help them. And that really was something everybody needed, foreigners maybe even more, because, in another country, language problems and like that, but even Maltese, with genuine issues within their family. I mean, we had some parents with challenging, very behavioral children who were there, they have their routine, their routine maybe, every day, twice a day, they take them for a drive in the car, or take them out somewhere, and they couldn't. I mean, it was devastating for them, they just couldn't cope. And that's why, and then the mental aspect, I mean, everybody is seeing how it got out of control, because people just went into a depression. I mean, you think, okay, it's only 14 days, because we had a quarantine for 14 days. But those 14 days, especially the second week, was too much. It was too much of a burden for many people.
And I think what I'm wondering as well is you will have the people providing the service, providing the care, providing the advice. You said just now, your population were asking you and your colleagues for their telephone number for support. And I just wonder, this must have been very, very stressful for your staff, for your colleagues, for your teams, because they're not used to having those personal demands on them. And that personal
my phone. It was my number, so it was phoning at all hours and messages. But I mean, for the people, it made a difference. It reassured them. And I didn't mind. I mean, we were here. It was tough, even not for all of us in public health, I would say. It's been almost now a year and a half. I mean, it's taking its toll on us. But I think this was a time where we had to be there for the people.
Thank you. Hugh, you're on mute.
Sorry about that. I suppose we're at a really interesting juncture as well, aren't we, at the moment, where people are experiencing COVID-19 fatigue, but we're at a really crucial stage where we're trying to also communicate, the measures still, but also now trying to communicate vaccine rollout and the importance of getting the vaccine. And I think, partially it's not so much outlined in the framework, but I think the framework is a way of dealing with that kind of disassociation with the risks now. And again, talking about reinvigorating the message, how do you reinvigorate the previous messages while introducing this new topic of vaccines are going to save your lives, vaccines are going to protect people, and how, because it's pushing the vaccine, but also still pushing the other measures as well. It'd be interesting to hear how others have found that balance. Got a hand, Naomi, you've got a hand raised. I don't know if it was about that, what I said there, or please be coming with something else as well if you like.
It's just more of a generic sort of communications query, really, from a place of not knowing, I suppose, as the rules are sort of relaxed now and become more nuanced, how you communicate and message around that is, I suppose, from sort of the next few weeks, people will be able to eat indoors together, and that's within the guidance, but doesn't necessarily support social distancing in sort of all places that you'll be able to do that. I just wonder how you sort of manage that discourse then.
I mean, I'm happy to give a view and then open it up to others who will have a slightly different experience. And if Katrina is still on, she may want to comment on this particular piece. But I think this is where the strategy around helping people to live lives to the full and reducing risk at the same time comes into play. So I think that what we need to help people do is to self-assess the risk. And I think in THL we heard that example as well. So people need to understand how they can assess what is risky or not for them, or what the gradation of that might be. And equally from a communications perspective, I think it's our job to help explain the risk, but also to explain how you can make things as safe as possible. So giving people choices that they can take for everyday activities that can help them to reduce the risk. So I think that's where we can contribute. But again, like I said, I'm really here to keen to hear rather from other people on this call who might have a different point of view or something they want to add.
On what you said with regards to the rollout for the vaccines, we are sort of like putting responsibility on people, like parents, sort of, you need to take the vaccine so you can protect your children because they can't take it. You need to take the vaccine because you have to protect your colleague who's pregnant at work. Trying to, instill in people, be there for others, do your role, this is your responsibility now, and trying to push on that.
Definitely, and I think that strongly links that understanding people motivations. That's linking again back to the framework, and I think Katrine, you've got your hand raised there. I don't know if you want to come in on that. I don't want to steal your thunder. It's your baby.
I just wanted to follow up, and I completely agree with what Leah said about understanding how people can be guided to reduce risk in their everyday life, and I think the strategies still relate in this situation. I just wanted to mention that from the WHO side, our communications department have created an online campaign that they call "Do It All," and to be honest, I don't know if it's been launched yet, but it's a campaign that sort of uses the logic of the weather, and so when it's raining, you're not just wearing rain boots, but you will also be wearing maybe an umbrella and a raincoat. And when the sun is shining, you're not just wearing your sunglasses, but also sunscreen and maybe searching for shade. And when it's very cold outside, you're wearing a hat and a scarf and a coat. So that's the logic. And so they call it "Do It All." And the key message is very much about individual behaviors. So even if you're vaccinated, also continue to use, wash your hands and use a sanitizer and ventilate and keep 1 meter distance. And these are things that we can do in our everyday lives, even if we go back to school or work, or even if we start being social with people or go back to restaurants. We can uphold those very basic individual measures, protective measures. So I guess maybe that will be one of the key messages, that we have to continue with these measures for a while still. We all still don't know what what will happen at the time when most of us have been vaccinated. So
yeah, it's really, isn't it? Oh, go on, yeah.
I was just going to say, I think that analogy that you gave there, Katrina, around the weather, you wouldn't just use your Wellington boots without a raincoat, I think is something that would resonate very well here in the United Kingdom, where our population is obsessed with talking about the weather. So I'll definitely be thinking about how we can use your idea there.
That's wonderful. I will share. I'll just reach out to my communications colleagues and see what we can share with you.
Fantastic. Just to link back to Naomi's question as well, I think part of it is understanding your different segments of your audience as well, and how you tailor the communications to those. So you're talking about going indoors to a pub. An older person may have a very different motivation compared to a younger person. They may have very different behaviours in that space as well. So it's understanding kind of that as well, and how you tailor the communications to that. And we're doing some work at the moment around a young people focused campaign, looking at addressing those behaviours, but also addressing how we need to speak their language and how we communicate in a way that's relevant to them. Again, they're not going to be they may not be looking at our website, but they may be on TikTok, they may be on Snapchat. I don't even know if Snapchat's still a thing anymore. I feel really old myself now. But it's understanding the spaces they occupy, what their motivations are, and appealing to that and communicating it in a way that's relevant to them as well.
Yeah, definitely, that's great. And the same, I really like that analogy of the weather, and just because you might not be doing one thing to do all the others, and continue with those.
Fantastic. Were there any other questions, centered around the framework, peripherally around it as well, in regards to risk communications measures? Nope, doesn't look like that. Well, we can, if people have any other observations they want to share in, drop it in the chat. We're also going to I'll also pop in the chat there just a very short survey. It'll take about 3 to 4 minutes to complete, just bit of feedback on the webinar, how you thought it went, what you enjoyed about it, what you didn't enjoy about it, if it met your expectations, and if you'd like to see more of this from the Sharp Joint Action, and what topics you'd like to see discussed if we were to do more. So just to really summarise from the day, really, I hope this has been really useful for everyone. It's been a really interesting exploration of both kind of, the communications and the front end aspect of it, and also some of the data gathering and the opportunities for engagement that kind of feed into that kind of the outputs as well. So it's been a really thorough, in my eyes, a very thorough kind of exploration of that. And I hope it's been really useful, of some really good examples of how you can apply it in your own countries, and how you can link that back to delivering on some of those areas within the framework as well. So thank you so much to all of our speakers, and really wonderful, engaging and brilliant looking at presentations as well. And just a reminder that they will all be available in the Padlet that was in your invite, in some of your reminder emails as well, and in the chat here as well. So please do click back in there. The recordings of the session will be in there. There'll be an overall recording of the session, and we'll also have the individual presentations recording as well. Fanny mentioned earlier about sharing some of the materials from some of what we've talked about today as well, so I can certainly pop some of ours into that Padlet as well, and I'll invite out to some of the speakers to see if they can share any further assets, or if anybody attending has some great examples they'd like to share with us. There was in that invite and in the Padlet information on how you can share some of your examples and how you can share some of your insights. It doesn't necessarily have to be in the presentation template that's provided. So if you have any existing presentations or materials or outputs that you'd like to share, we'd really appreciate any examples, because again, what that will help us do in relation to our remit as a joint action, it'll help feed into that future preparedness and response planning and help inform future risk communications approaches that can, as has been pointed out, adopt that COVID-19 fatigue principle and the approaches needed to address it. So thank you so much, everybody.